Hey, it's Rob Potash with CSMI, and welcome to episode number, Johnny,
11.
number
Number
12.
10.
Nothing goes to 11 except Nigel's face. Episode number 10.
Number 10.
Number 10. Johnny and Daniel, thank you for doing such a great job on building the content and getting us into double digits. On this episode, they're going to cover lower extremity exercise and testing, and they're going to bring in some pathologies. Also, if you glance to the right side of your screen under handouts, you'll notice there's a handout. Daniel and Johnny were kind enough to make their slides available before the show. So if you want a hard copy of the presentation, you have it. That's what I have to say. Enjoy the show, Johnny and Daniel. Have at it.
Well, let me just say this one thing. No one except my mom has ever called me Johnny, and that was when I was about 3 or 5 years old. So I'm not sure where they came from, Robbie, but you know, it's all good. It's all good.
And John, welcome back. Where were you traveling to most recently?
Most recently, I was out. I think I talked to you guys when I was out in Montana and Denver.
Mm-hmm.
And after that, I was out west a little bit further, Vancouver, and then to Hawaii to Hilo. So hi to all my Hawaii connections that I visited. I'm wearing the shirt that you guys gave me, and back home and ready to kick some stuff.
All right. Well, let's go ahead and take our webcams off, and we'll get started.
Sounds good.
All right. Let me make this full screen for you. All right, so we have made it to, oh, where did we go? All right, I think we're up and running. Okay, we made it to episode 10. You've seen these screens before. Like us on Facebook, CSMI, myself. If you have questions, send them to Rob at rob.potash@CSMI Solutions. That's good to get questions after the fact from anybody that's watching us live but thinks of questions later, or anybody that's watching on the recorded session. That way we kind of know where to guide and, you know, maybe some things to throw in the next episode, or even email you directly. You can always register your clinic for free at cybextest.org. That way we're building a platform so patients and physicians can find your clinic and send patients to you for testing. You can always go to isokinetics101.org to catch up on previous episodes, and that's going to be really important tonight because we're going to cover a lot, and we'll mention things, and if you're unsure of what I'm talking about, you can always reference it from previous. All right, again, tonight we are going to cover lower extremity plans of care for various pathologies. Next month, John's going to do the same thing for upper extremity, and then in December, we're going to do a little potpourri episode for you. All right. We have seen this before, the 5 phases of rehab, you know, range of motion, stability, strength, control, and then testing. So we're going to cover all this tonight for the different pathologies. The key is fit your patient into where they need to be treated. We're going to kick this off with what we get the most questions regarding, and that's the ACL Plan of Care. So when your patient comes to you for prehab, lots of times you'll see them prehab as they're allowing the other ligaments or a bone bruise to heal before they have that surgery, and they come to you for some care. So what you can do with your ACL patients at this point is just doing CPM, get that mobility training. That's going to reduce that pain, the swelling, and it's going to really kind of help out with that. Let me minimize this other screen here so I can see my full screen. Okay. You're going to regain their range of motion. All right. If you're able to, you can do some very light isometric contractions at 60 degrees, that angle only. Your focus here is on neuromuscular re-education, just getting that quad firing. All right. Later, we're going to talk about a proximal pad for the quad. So you're going to get some good research and reasoning for that. But just know for right now, again, you're going to put that pad proximally. That way you're unloading that shift, okay? That anterior shift of the tibia. If you're going to do any hamstring training, let's say you know that they're going to have a hamstring graft, you want to work the hamstring a few times before that, you can go a distal pad for isometrics at the hamstring. Here's a big key. When we did the isometric episode, I mentioned how you can test the uninvolved limb for a comparison later on. We call it the EPIC, or the EPIC comparison. Now is a good time to get a good either isometric or even better, the interrupted stroke isokinetic test, because that uninvolved limb is going to lose strength over the next 4 to 6 months as they're rehabbing the involved side. So testing them now right after their injury will give you a better comparison later on when you're trying to make your return to play decisions. All right, so now patient has their surgery. All right, they have their surgery there. All right, just let me know, guys, if we have anything up on the screen, okay? Sorry about that. Again, patient has their surgery. Their first 1 to 2 weeks, you want to run this as a CPM only. You're just working, again, on reducing pain, swelling, and you want to regain that range of motion. That's your goal here, is just getting that range of motion back. And so that's all you're worried about in your first 1 to 2 weeks as far as the dynamometer. Now, not just now, but throughout the entire plan of care I'm going to discuss, you're still going to do all of your regular ACL reconstruction interventions. And what I'm talking about tonight is only how you would use the dynamometer or the isokinetics for that. Okay, it looks like we're good to go. All right, now we're 3 to 4 weeks out of ACL reconstruction. What we can do at this point is you can begin the eccentric unloading. And again, reference back to the isokinetic chapter or episode we did where we talk about our eccentric progression. The first step of that is the eccentric unloading. We want to do that at 5 degrees per second. And again, you're looking at quad activation here. And most importantly, the terminal knee extension. Now you're not loading into the pad. Go back and watch that video. They're not giving an external load to it. They're just unloading the weight of their own limb. So with this, we're gonna run them a full range of motion all the way to extension. And again, that's just to get that quad firing under the weight of its own internal forces. Still in this phase, you can run CPM as needed to reduce pain, swelling, and regain range of motion. And this isn't just in sitting. This works really good in the prone position as well. You know, we have a lot of our patients doing prone hangs to get that terminal extension. Well, running the CPM in the prone position is really good to help get that terminal knee extension, as you can provide a very light load into that terminal extension to help them out. And it's a fantastic, fantastic intervention there. Now, the next thing I'm going to talk about is the uninvolved limb. And I'm going to mention the uninvolved limb throughout this. If you have the ability and the time in your clinic and with your patient, you can train their uninvolved limb as well. So this is a good time to teach them multi-angle isometrics for the uninvolved limb, because you're going to teach the patient this in the next 3 or 4 weeks for their involved side. So it's not a bad thing to show them what's coming ahead for their surgery leg, but it also gives you a chance to continue to work that uninvolved limb and reduce how much strength it's going to lose throughout the plan of care. Same thing as far as the eccentric progression that we've mentioned before. Start that eccentric progression for the uninvolved limb at the slow speeds, 5 degrees per second, 10 degrees per second, 15 degrees per second. Start at light contractions on that other leg to maintain their strength. All right, so before we go into the next phase where we actually start loading the surgery knee, I want to give you a little bit of research as far as anterior shearing and ACL strain. Now, the native normal ACL, it can withstand up to 2,000 newtons of force. Now, when a patient has an ACL reconstruction and they're doing open chain exercise, knee extension, they're going to have the least strain on that ACL between 90 and 40 degrees. And if we look at our graph here, let me get my mouse pointer going, along this y-axis here, what we have is ACL strain or force in newtons. Along the x-axis, this is a graph of an open chain knee, okay? Sorry, of a leg with the knee joint right in the middle, and you have little arrows, and the arrow is indicating where the load or the pad is placed along the tibia. So this first one where it says 10, that indicates that it's 10 centimeters from the joint, and you can see the arrow there. This middle one here, this is 20 centimeters, and this is where, when we say a proximal pad placement, we're talking the middle third of the tibia. And then if we go further out, this is 30 centimeters. So we're getting closer down here to the ankle where my mouse pointer is. And all the way to the right, this is a full distal pad placement where you have the adapter pad right at the medial malleolus. So research tells us that if we use a proximal pad, which is in the middle third of the tibia, we will reduce the strain of the ACL in half. And I'm talking 200 newtons right here. And this is at 30 degrees. So if we take the 30-degree line, which is right here where my mouse pointer is, I'm circling it. If we load 30 degrees of active extension at the knee against a load, we have about 200 newtons. Now the same load, but the only difference, we load it up at a distal pad placement. Again, let's follow that 30-degree line. Now we're 400 newtons. So by putting that pad in that middle third of the tibia, we've cut the strain on that ACL by half under an external load. I have the article at the bottom there, and you can see there's a couple big heavy names there, you know, Andrews, Wilk, big names in the rehab world. So these people know what they're talking about. It's an outstanding paper. All right, for comparison, this is another great study that was done here. And there's this one, there's many others like it out there. They looked at strain on the ACL during just normal level ground walking. And with every step our ACL reconstructions patients are taking, they're loading 300 newtons into that ACL. And that's listed right here. The ACL is the heavy black line. And they have it as CTO, or contralateral toe off. Basically, it's when they're in that early stance phase. The quadricep is firing. And here's the funny thing, it's a closed chain activity because the heel is on the ground and the hip and hamstring is acting to extend the hip. So even in our closed chain, normal activity that all of our patients are doing, they are getting more load, 300 newtons, on that ACL, let me go back one, than they are if we loaded them at 30 degrees, a 30-degree angle with a proximal pad. And here they have another one, stair climbing is 146 newtons at 50 degrees. Now, I'm assuming this is climbing up. I would love to see what it is for going down a stair, because we all know down the stair, you're gonna kick in that quad eccentrically. There's a much larger knee moment, or a knee flexion moment occurring. So I'd love to see what the amount of strain on the ACL going downstairs is. So this graph here, what I did, I tried to scale both of these. So you can see I circled the 300 newtons on this graph and the 300 newtons at this graph, and I tried to scale them so they'd be equivalent. And you can see, you know, we're getting less strain on the ACL with the proximal pad at 30 degrees of extension than you do with every single step that you take. All right, that being said, at week 4, somewhere between weeks 4 and 6, depending on your patient, you know, if somebody has a patellar bone tendon bone graft versus a hamstring graft, they might be a little bit more in week 5 or 6 versus somebody who had the hamstring graft. But either way, in this phase, we can start multi-angle isometrics. Now, our research tells us that we get a 10-degree plus or minus over the angle that you exercise at. So if we exercise at 40 degrees, that's going to strengthen 30 degrees to 50 degrees. So we're going to do every 20 degrees, and you can start from 40 degrees of extension all the way to 90. Now, I like to do 3 to 5 reps at each angle, and then it moves to the next angle and it runs through the motion. John likes to do 1 repetition at each angle, and it runs all the way through, and then it repeats back, and he'll have the person do this, one time through, or maybe even 3 to 5 times through. That's his preference. Either way, you're going to do a 5-second contraction with a 10-second rest. Again, we're going to set our angles every 20 degrees, 40, 60, 80, and 90 degrees. Now, I'm going to tell you this. John and I have used this modality for starting at 20 degrees. All right, and you go back to the graph that we showed. Right here, you say, well, 20 degrees, that's right around in this range here, which is still a little bit below 300 newtons, which again is less than walking, but I'll get off that little soapbox right there. Again, you're going to use your proximal pad for the quad. If you're doing hamstrings, and we'll get more into the hamstring in a moment, but you need a distal pad for the hamstring. You want to have it lower toward the ankle when they're pulling with the hamstring to unload that shearing. Now, we're going to still talk about this a little bit, because I mentioned before that John and I are doing this for neuromuscular reeducation and also at 20 degrees. You got to go back to this graph John has showed you over and over. Your torque curve. When we're looking at our quadricep, we're going to peak out right up here where my mouse pointer is, around 60 to 70 degrees. If we go to the right, that's going towards 80, 90, 100 degrees. If we go to the left, now we're going 50, 40, 30, 20 degrees. So down here, if we're going 20 to 30 degrees, you're going to get a much lower torque production just from simple cross bridging from lever arms. So you're naturally going to get much less. So when we are having our patients, contract at 20 or 30 degrees at this point, we're talking very light torque, right? As that knee moves into deeper angles, your patient can then produce higher torque. So when there's if you start out at 40 degrees, again, that's what research is recommending. So I'm not saying everybody go out there and load at 20 degrees or 30 degrees. Your surgeon has to be comfortable with you doing it. You have to be comfortable with your patient doing it. There's a lot of safety features you can put in, right? You can set torque limits when you write your protocols. Go back, episode 4, I did a protocol editor video on how to write multi-angle isometrics. You can set a 5-pound or 10-pound limit on those earlier angles. As your patient gets stronger and they're in the 40, 60, 80, 90 degree range, still have torque limits in your protocol. That way, if you step away and your patient decides, hey, let me see how hard I can push, if it hits that 15 or 20 foot-pound limit that you set, the machine's going to shut off and it's not going to allow them. The other thing you can use is your targets feature. Not only is that good for neuromuscular control and making your patient really focus on keeping that torque controlled and steady, if they go above it, well, exercise stops. It won't allow them. If they go below it, it stops. So those are two really good safety features that you can put in. But again, research tells us exercise them from 40 to 90 for their first from week 6 to about week 12. Now, if your patient had a hamstring graft and or a medial meniscus repair, you do not want to perform hamstring isometrics until week 6 at the earliest. That harvest site needs to have 6 weeks minimum, maximum 8 weeks in order to heal. If you had a medial meniscus repair or even a posterior meniscus repair, you need to you cannot perform hamstring strengthening or isometrics because it's going to pull on that repair. So if you have hamstring graft or meniscus repair, do not do hamstring isometrics until week 6 at the earliest, but it's safe to do quads. At this point, again, week 4 to 6, I want you to continue progressing through that eccentric progression for the uninvolved limb. Get that strength up. Don't forget about that leg. And again, that's if you have time. We understand if you're running, 2, 3, 5 patients at a time, hopefully you're not, but if you have that situation and you don't have time for it, or you have multiple athletes that need to get on your machine and you don't have time for it, then you don't have time for it. But if you get a chance, try to run your athlete occasionally on their uninvolved limb, not just to get strengthening, but you can see how they're progressing on that other leg. All right, week 6 to 7 after an ACL reconstruction, progress the isometric torque production. If they're comfortable loading, 5, 10, 15, 20, 25, 30 foot-pounds, that's good. You don't need to go any higher than that. Again, it's more about contraction control. You're not trying to get strong at this point. Remember, when you first start an exercise program, your first 6 to 8 weeks are neuromuscular adaptations. And that's what we're in right now. We are doing neuromuscular adaptation. We're not into hypertrophy phase yet. That's not going to start until weeks 12 to 14. So again, keep your torque low and just work on control. Depending on your patient, you can begin our slow eccentric progression for that involved surgery leg, usually between week 7 or 6, 7, or 8. We start it very slow at 5 degrees per second. And what we'll do is we'll just run them through one set of 10 reps the first time they're on the machine. Sometimes we'll have them do a set of multi-angle isometrics as a warm-up on the machine, and then we'll do a slow eccentric 5 degree per second, just 10 reps. And then the next time they're in the clinic, then we'll have them start with one set of that 5 degree per second, and then a 1 or 2 minute rest, and then another set. Again, light torque production is your focus here, contraction control. After they've done that and they're showing you that they have good control of their quad, they're not having any pain during, they're not having any increased symptoms after, now you can slowly start to progress those speeds, okay? You want to keep your torque effort or your output effort low. 25% effort, working up to 50% effort maximum at this point. So it's very light. So when we write our protocols, John and I like to run 3 sets of 10, which with each set progressively faster. Now we name them a little different. I like to name it for the speed that the patient's contracting at. John likes to name it for, he names it for the resting speed, but he does that because he wants the clinician to know what the maximum speed is going to be, and we like to put that slower resting speed twice as fast. So we're saying the same protocol. I say it's 5, 10, 15 degrees per second. John's going to call that 10, 20, 30 degrees per second. But we're talking about the same protocol. Again, you're going to keep this proximal pad on the quad until about week 16. You're going to see that coming up. Keep it distal for the hamstring. As far as run involved limb, at this point, get that thing strong. Work your way through that eccentric progression. All right, next, I have a very short video, and this is the only video that we have this episode on how to actually create an eccentric exercise protocol. Let me find where this is, minimize here. All right, here's our video.
To create an exercise protocol from the main screen, click on Utilities and then Protocol Editor. From the drop-down menu, select the pattern Knee Extension Flexion. Select Exercise and then click Add. This protocol is going to be 3 sets of 10 with the eccentric speeds at 10 degrees per second, 15 degrees per second, and 20 degrees per second for the quadriceps. Click the Add button. Now here's the key. In the mode box, select CPM. When you select CPM versus isokinetic, the patient gets to completely rest in the resting concentric phase. Put the trial reps to 0, but the termination of the set, make that 10 repetitions with a 60-second rest. The speed of the first set is 10 degrees per second for the eccentric quadriceps. Now that corresponds to when the machine is moving into flexion. So the second box on the right, we're going to set that at 10 degrees per second. Now John and I like to make the resting concentric speed twice as fast for 2 reasons. 1, it makes the set go faster, but more importantly, it helps the patient know when to contract and when to relax. Now the protocol I'm creating today is very slow, 10, 15, and 20 degrees per second. So that means that this is something done earlier in the rehab process and you don't want them to push very hard. Therefore, in this video, I'm leaving the torque limit.
So Daniel, I want to interrupt you for just a moment if I can. I know you're going to be loading that. And I want to talk about that week 6. So really what we're talking about is nomenclature. It's how we're naming things.
You're going to want to
Since some of the things that we did, no one was doing this before. It was
other than that,
so I'll let you go ahead and take it.
Anything else on this screen or on the feedback screen because it's already set for torque versus position. Now we just have to add the second and third set. So click the Add button, and then the speed for the second set in the eccentric quad is 15 degrees per second. So let's go to the box on the right and change that to 15. We'll have the box on the left, the concentric speed, twice as fast, 30 degrees per second. And now we'll do the third set. click Add, and the speed for the third set in the eccentric quad is 20 degrees per second. So the box on the right will be set to 20, and the passive concentric, the box on the left, will be twice as fast, 40 degrees per second. Go down to the rest and change that to 0 seconds. Click OK. If you need to, you can check your settings, but when you're finished, click the OK button. This takes you back to the protocol editor screen, and you can see the protocol you just created. But when you're finished, click the OK button at the bottom.
So Daniel, I know that there's a little bit of an issue associated with it loading. So I want to kind of just talk. I want to talk a little bit about the nomenclature again, what we were talking about, and see if we can make sure that people understand what we're really talking about. So when I name something eccentric loading, what I'm really saying is that if we go eccentric loading at 10, 20, 30, we know that the fastest speeds are going to be that we're actually going to load during the eccentric phase half of that. So our eccentric speed, if we say 10, that's the concentric speed. The eccentric speed is going to be 5. If we say 20, it's going to be 10. If we say 30, it's going to be 15. But when we switch it around the deceleration training, that's when we actually talk about the eccentric phase running at a much higher rate. So as deceleration training, we're increasing the speed eccentrically, and see if we can push forward from that. So we're loading it eccentrically. We're increasing the speed of each one of those
Hey, I think I'm
over
back.
that number. Okay, great, Daniel.
All right, so we are going to skip the video because that obviously wasn't working. What I can do is I can always throw it up on my YouTube page and put it on next episodes, or I can even send it into Rob and we include that link. But either way, it's not worth having a pause in the presentation. So we're going to get back into it. How does that sound?
Sounds good.
All right, let me make sure we're showing the presentation again. Okay. This is where we left off, and we are going to skip that video. All right, back to week 6 to 7. All right, if you had a hamstring graft or medial meniscus repair, this is when you can start loading that hamstring. You can do this in the sitting position or the prone position. Some research out there shows it's easier on the ACL, or really it doesn't matter. I hate doing prone hamstrings. Being an avid lifter, I hate doing prone hamstrings. Not only that, the patient can't see it in that prone position. So I really like doing it in the sitting position. The downside of sitting is your hamstring is elongated versus laying prone. So John, he likes that prone position. I like to do it sitting. But we'll move on to the next. In episode 6, I talked about isotonic control training. This is when you can start doing this for your quadriceps. We're talking about doing the reaction time application and the proprioception from the dashboard. You're not going to want to put any additional load on it. The adapter in the pad, when they're in full extension, can weigh up, including the leg, has about 10 foot-pounds of torque on it. So you're not going to want to add any additional load. You can run this full range of motion because you're not loading it up, but it's a great time to get in there, and you just maybe do one set here or there occasionally in these few weeks, just kind of get them working that proprioception, joint control position, really work that control aspect. All right, so now we've moved on to week 8. Now, we know from research that at this point, week 8 to week 12 is when the graft is going to be at its weakest. Keep that in mind. What's funny, this is when we get our patients started running and doing a lot more active exercises, but it's always, I think it's funny, it's the weakest point, and it's when we're the most worried, but yeah, that's when we really start pushing them through with their functional stuff. But with the Isokinetics, you're going to continue that slow eccentric progression. Here's some general rules. You want to do each protocol, whether that's 5, 10, 15, or 10, 15, 20, or 20, 25, 30 degrees per second. Either way, you want to do each protocol at least on at least two different sessions. Now, I put a little asterisk here because you have some patients that are coming in twice a week. You might have some patients that are coming in once a week or even once every other week because their visits and their insurance. So keep that in mind. If they're only coming to see you once a week, if they did really well on 10, 15, 20 degrees per second, the last time we were there, I might start with that when we get on the machine. And then the next time, then their next set, I'll take them to the faster speed. So, take that, performing each protocol in at least 2 sessions with a grain of salt, okay? You want to do 1 to 2 sets per session. And you're doing this generally at the end of their session. They come in, you're doing a warm-up, you're getting them in their close kinetic chain exercises, you're starting to get into other planes of motion, you're going to do some proprioception work, and then they're getting on the machine for the isolation. So again, use the machine at the end, and you're only going to do a couple sets of it. You're still keeping them only 50% effort on that involved limb. Remember, they're still in that neuromuscular reeducation phase. They haven't hit hypertrophy phase yet, so keep the torque low. You're progressing them by making the speeds faster. So you don't want to load them up on the torque amount. Since we're really hitting eccentrics, that eccentric as the speed goes faster, it really changes how the neural firing is occurring. So keep that in mind. On that uninvolved leg, let them go up to 75% effort. And you're probably getting into the medium speed deceleration training. Again, John has discussed that in the isokinetic one. That's something to keep in mind. You're still going proximal pad, middle third for the quads. So this is what we consider our slow eccentric progression. Each of these is, let's take that first line, 10, 15, 20. That's a set of 10 at 10 degrees per second, a set of 10 at 15 degrees per second, and a set of 10 at 20 degrees per second with a 60-second rest in between. When I said, do each protocol 1 or 2 times before you're moving to the next, well, the next is just taking that middle speed and starting there. So 15, 20, 25, and then 20, 25, 30. And when you get to 35 degrees per second, that's 35 degrees per second for about a 70 to 80 degree range of motion. That's half. And as John has explained to you before, that's how we consider it to be slow eccentrics, because your speed is half that of the range of motion that you're working them through. At this point, as far as the isotonics, you can load it up a little bit, 5, maybe 10 pounds for your big, strong athletes. The applications you want to use here are the interactive line and path, the pacing bar and the roadway are really good, and also the games, the breakout and pong. This is really good to do at this point, okay? I like to do this after the strengthening. So let's say they do 2 sets or 2 protocols of 20, 25, 30, then give them a few minute rest, then we'll run them through it again. And then I'll put them on a game or one of the roadways or the interactive line or path. Not only do your patients really look forward to doing it because it's fun, but at that point they should be fatigued out with that muscle, and having them have to now control is really tough. So do this after at the end. Now at week 8, this is when you can do your first isometric test. You can test the quadriceps and the hamstring unless that hamstring was used as the graft for the medial meniscus repair. If they just started doing isometrics, you're not wanting to load them, for a test. This is your baseline test. You want it to be completely pain-free. You're going to test them at 60 degrees, 3 reps, 5-second contraction, and 10-second rest. We covered that in the isometric testing episode, so refer back to that if you need to. So we are now week 12. this is when you should be trying to progress them faster into the medium speed deceleration training. You can allow up to 75% effort because now they should be transitioning into that hypertrophy phase. They should have, really worked those neuromuscular adaptations. You've worked really hard on, teaching that quad how to contract and continue to produce torque as that knee flexes. And now you can really work on strengthening. This is when you're going to see that eccentric inhibition, or those force oscillations that we talked about in the past. So you want to train through that. You don't want to progress your patient to the next speed of the protocol if that quad is still jumping around. So train through it. Don't progress. Don't push through it. Just train through it, but don't start loading on more torque and more speed. Keep that pad proximal at this point, okay? You can now strengthen the entire range of motion into full extension. But John and I, we don't have our patients go all the way to full extension. We stop them at 10 degrees because those last 10 to 15 degrees is when that knee is going to go through the screw home mechanism, and you're not wanting to load that knee eccentrically in that screw home mechanism. Even under these lighter loads, you're not going to want to, and you especially aren't going to want to when they're actually producing high torque. It doesn't feel good even on a healthy knee, so stop them at 10 degrees. Again, eccentric, it's a different exercise than the concentric, the standard concentric, okay? These are the speeds I talk about when I say the medium speed protocols. Again, if we take the range of motion, 10 degrees to 80 degrees, that's 70 degrees total. And
hey, Daniel.
Yes.
Sorry to interrupt. The slide's not advancing. Can you check that real quick?
Absolutely.
I'm looking at video.
What slide are you seeing?
Yep, video, create an eccentric exercise protocol.
Oh,
Yeah, we're
okay.
back on slide 16.
Oh, I'm sorry.
That's okay.
No worries. Now you got it.
Okay, well, then I will go back to
That boy.
Yeah, and again, if you don't have the slides, you can go through. This is where I was talking about doing the isotonic control training in week 6 to week 7, and you can start the hamstring isometrics. This is what I was talking about with, our progression rules as far as progressing each protocol. And these were the slow speeds that we were talking about for 10 degrees per second through 35 degrees per second. Those are the different protocols that we like. Again, a set of 10 for each speed, 10 degrees, 15 degrees per second, and then 20 degrees per second. And this is the graph that we always showed with the isotonics. Again, week 8 to 11, that's when you can start the interactive path, the games, the pacing bar and roadway. Again, light torque, 0 to 5 pounds, not loading up heavily, and do it after you're strengthening to get that neuromuscular adaptation. This is the slide I talked about with testing your first baseline test at week 8. And then I believe we are caught up now. So around week 12, medium speed, allow 75% effort, progress them when their torque lines are ideal, work through that eccentric inhibition, don't push through it to the next speed. You can keep going with the proximal pad, but you can now strengthen that full range of motion, but don't load them eccentrically into those last 10 degrees. Here's our medium speed protocol. So starting at 40 degrees and then 60 and then 80. So when we're on the slow speeds, each speed increased by about 5 degrees per second. Now you can see we're increasing 20 degrees per second each time. So you're getting much faster progressions of the velocity in these medium speeds. And you're also loading up to 75% effort. But again, run each protocol 2 to 3 different times and 2 to 3 different sessions. And this is where you're going to see that neurologic inhibition. So don't push through it, train through it. Now, the ways I like to do are medium speeds. You can do agonist muscle where only the quadricep is contracting, or only the hamstring, or you can do agonist, antagonist. So let's go over these each. So our agonist sets, this is what we've been talking about, an active eccentric, but the resting concentric. So that's what we've been talking about so far. Now you can also do active eccentric and active concentric. So this is where you're truly running the machine in isokinetic mode. If my video played, you would hear me say that you want to set the exercise up as a CPM so that way they can completely rest in that concentric. If you run it as isokinetic, they have to push into it. But in the medium speeds, if we're doing the active, eccentric, and concentric, you're going to run it as an isokinetic mode. Now they're having to push in both phases, but they're only still using one muscle. Now this is really a great progression because it takes more oxygen concentrically, and you have a much greater time under tension. So doing a set of 10 of eccentric and concentric will smoke that patient's leg out really fast. So it's a great way to keep the same speed, keep the same effort, but add another layer of difficulty. If we do agonist antagonist, that's where we're doing the quadricep and the hamstring together. I like to do what's called alternating sets. That's where we do one set of 10 for the quad, but they're only doing the eccentric. I'm still having them rest in the concentric. After they do their set of 10, then they have a set of hamstring. I give them a 10-second rest, and then they're going to do a set of 10 hamstring eccentrics. And then it goes back to the quad, but now it goes to that second speed. So let's use 40, 60, 80 as an example. I'll do a set at 40 degrees per second for the quad, and then a set of 40 degrees per second for the hamstring, and then 60 degrees per second for the quad, 60 degrees per second for the hamstring, and then 80 degrees per second for the quad, 80 degrees per second for the hamstring. You're working both muscles, but the reason why I like this is if you did, well, that was what, 6 sets of 10, and you had a minute of rest in between each of those, you are spending more time on the machine, or your patient's spending more time on the machine resting than they are exercising. So by doing one muscle group at a time, while that hamstring is exercising, the quad gets to relax. So each muscle is still getting about a minute of rest, but you're cutting down on that time. And especially if you have a clinic that a lot of patients are needing to get on your machine, or you have a short time limit, some clinics only get 30 minutes with each patient. So if you can cut that rest time down significantly, you can really maximize the time on the machine. The other way we do agonist, antagonist, don't do it a lot. It's the reciprocal pattern. This is where within each set of exercise, they're doing a concentric quad and then a concentric hamstring. That's the basic standard isokinetic training. I can't tell you the last time or any time I've ever had a patient on the machine to do this, other than just to show them how what we do is different from everybody else. That's the only time I ever actually run through it, just so they can see that, that they're getting much more out of it than the standard isokinetics. Again, week 12 to 16, this is where I like to do that 30% eccentric overload on the machine. So if they're, again, it's isotonic, okay? So it's that constant resistance. So if I have their concentric torque at 10 foot-pounds, I have their eccentric at 13 foot-pounds. We're still doing the interactive line and path, the games, the pacing bar and roadway, so the same things that they were doing in the last phase, but throwing that little 30% eccentric overload really makes it harder. And if your patient can't do 10 to 13, start them out 5 to 7 foot-pounds. So much less. I've only ever taken one person all the way to that 40 and 52 foot-pounds. Most people are training on this at 10 to 13 or 20 to 26. Again, I do this after fatiguing out those muscles, so it's working on endurance and control. So you don't need to load it up heavy. At week 12, this is when you can repeat your isometric test. All right, if you had that hamstring graft or that medial meniscus repair, go ahead and test that muscle now. But this is where you should see a difference between week 8 and week 12. So again, this is your progress report for their strength. Now this is where it starts to get a little bit different. Based on your patient, their plan of care, and what they have going on, they might stop coming to see you as often. They might see you once a week, every other week. If they have an athletic trainer, a strength coach, an independent gym program, they're probably not going to see you as much. But if you still have some patients that are seeing you twice a week. Depending on what you're doing, if that time with that patient, if you're able to fit in, the power training that we covered in episode 6, it's a fantastic thing to do at this point. That really works on that rate of force production, and it gets your patient strong really fast. So I love that doing power training at this point. You can progress your deceleration training, or that medium speed, into the high speeds. Now we don't get people much into those, maybe 200 degrees per second at most. We typically stay just in the upper end of those medium speeds, but some of your higher end elite athletes might need that higher speed. And you can also do your dynamic isotonics, just increasing from 10 to 13 foot-pounds to 20 to 26. You can begin doing a distal pad placement for your quadriceps at this point. Now, having that pad distally, your force numbers or your torque numbers are going to be higher just because now you have a longer lever arm. And at this point, I also like to use the machine in the middle of the session. We've been using it at the end of the session, doing a couple sets at the end. I like to do it in the middle because they come in, you warm them up, do a couple little close kinetic exercises, just as warm up to their plyos, and then I hit them with plyometrics and agilities. And then I like to put them on the machine for a couple sets, maybe 10 minutes, 15 minutes at most. And then I want to see how they do their close kinetic exercises and some of their higher end neuromuscular reeducation activities. Throwing them on a BOSU ball and throwing a weighted medicine ball to them after they fatigue that quad out or that hamstring out really challenges them. So again, you're not changing what you're not taking that proprioception harder, but you're making it harder because you've fatigued that muscle out. At this point, we're going to do testing about every 4 weeks. All right. So week 16, I like to repeat that standard isometric test. Now, if you like doing that, I like to do the isometric test at 16 weeks. If you want to do the standard isokinetic test, you can. Sometimes I'll have a patient do it just because, they've already done the isometric test a couple times and I want to make it a little bit more dynamic for them. If you think about it, concentric, you're going to get less torque produced than you would isometric anyway, but it's, I like to do it just because it's getting, movement during the test and you're working that full range of motion. Either way, at week 20, this is the earliest you can perform that first interrupted stroke test. Again, it's a baseline test for your interrupted stroke because you're going to retest them in 4 to 6 weeks because you need to find out, okay, are they improving with their quad but not their hamstring? Are they gaining, did they gain 40% strength in their hamstring but their quad only gained 20% strength? So it's a great time to retest and assess where you are at this point. Now, it's weeks 24 plus, that's basically 6 months. You're going to do repeated interrupted stroke testing about 4 to 6 weeks to help determine appropriate return to play. So we've talked about the parameters we're looking for with this. You should also test them in their functional tests. I love doing the T-test, trying to get that under 11 seconds. I love doing the single leg hop trio, for distance, the crossover, and the timed. So throw all those in there as well because you got to have the functional test with the isolated joint. So let's say at 6 months, they're not where they need to be. Have them work on it, come back in 4 to 6 weeks and retest if they're not still at your facility. If they're still at your facility, keep working them. But that way you can help determine when they're ready to go back. In the off season, have your patient come back about 4 to 6 weeks prior to their first practice. That way you know if they're ready to practice or if they need to hit their training hard for 4 to 6 weeks. Every one of John's pitchers always come in. A lot of times they travel across country to come and see him. A lot of our ACL patients would come in before the start of the season just to make sure they're ready to go. All right, we're going to go into a total knee. This is much faster than the ACL. With your total knee patients, as far as prehab, and you'll see a lot of them prehab, maybe not right before the surgery, but a few months leading up to their surgery. You can just run them through multi-angle isometrics or slow eccentrics. Mainly we're hitting the quad. You can do the hamstring if you'd like. Only run them through the slow eccentric loading, the very slow speeds, if it's pain-free. If they have a really arthritic knee, you might not tolerate the slow eccentrics, and you probably want to stick to that multi-angle isometrics. Now the patient has their total knee surgery. Their first 2 weeks on the machine, you're just running the machine as a CPM. Again, pain, swelling, stiffness, and range of motion. Starting in about week 3 or 4, you can begin that eccentric unloading for that quad activation and terminal knee extension. And around weeks 5 to 6, you can start, again, very light multi-angle isometrics. Here's the difference between total knee and the ACL, is you can do a distal pad and you can exercise the entire range of motion. Remember that extensor mechanism went through a lot of trauma in the total knee. So keep everything light and easy. And also these aren't going to be your elite athletes or highly active people anyway, so there's no need to progress them fast. Around week 6 to 8, you can begin that slow eccentric progression with the same rules that we talked about with ACL. Again, 25 to 50% effort. If it's appropriate to do an isometric test at week 8, you can. Typically, I won't. If they're heavy into cycling or tennis, or they're a very active person and they want to get back to that higher level, you can do a light submaximal isometric test at week 8. But I typically just perform it around week 12 when we're talking about discharging. Around weeks 9 to 12, keep that slow eccentric progression. You can go up to 75% effort as long as it's pain-free. Again, it's based on the patient. Everyone's different. Most of your patients aren't going to need to go beyond slow speed, and most of them aren't going to need to go beyond 75% effort. And you can also do some of the isotonics, but it's not as important. You do a follow-up test around week 12 when you're getting ready to discharge. With your non-surgical knees, basically do a test. They come in the first day, determine if they're appropriate for what kind of testing. Now, you can test them on the initial exam date, but what John and I like to do, and I learned this from him, is he'll put them on the machine as one of their interventions that first day and either have them do multi-angle isometrics or slow eccentric set. Again, this is your non-surgical patients, just knee pain. And he does it as a way to assess their tolerance for it. And then when they come back for their second or third visit, then he might do an actual test with them. Who shouldn't we test? If they're non-weight bearing on that knee, if they're not safe to transfer on and off the machine, if they have an acute injury, an inflamed joint, if they're just really weak, where they're giving you just very light contraction or high pain with manual muscle testing, not only should they not be tested, but maybe they're going to be one of our CPM or our mobility patients. Who should get isokinetic testing? They're ambulatory, they have full range of motion, they have minimal pain during normal activities, but it doesn't restrict their normal activities, but when they get into their more vigorous activity or exercise, that's when they get their pain. These are typically your trained patients. They have full strength or near full strength and minimal to no pain. If you put them on the machine and they did well with slow eccentrics that first day, go ahead and actually get a baseline test on your second or third visit. Now, let's say you did an isometric test on them and you really didn't find anything, then you can go ahead and move them to that next level of test. Again, typically we're only going to be doing the testing for your quadricep for this patient, but we like to do that interrupted stroke test for it. But you can do both muscles, but typically we just do the quad. As far as isometric tests, they have dysfunction, but they're not appropriate for the full isokinetic. So the ambulatory, they have pain with normal ADLs that restrict their activity. They're not trained. They have mild pain with manual muscle test or just less than full. Maybe their pain-free range of motion or the pain-free restricted range of motion isn't full. Or you put them on the machine that first day for slow eccentrics and they failed miserably. Either they didn't tolerate it well or that their muscles just weren't firing. Well, there's no point in testing them under those conditions, so go ahead and dial them back to isometric. Either way, they're going to fall into 3 categories: passive training, isometric, or eccentric. Again, just like the ACL, you do your dynamometer at the end of the session. Find out where they fit on this continuum of care. All right, let me finish this up and then I'm going to invite John back in. You'll have the slides to go over the ankle, so you can look at that. So I'm going to finish up on the non-surgical knee and then I'll invite John back in. Our passive patients, typically we have them on there 5 to 10 minutes at most, or 5 to 10 degrees per second. So this is your acute injuries, muscle strains, a really sore, stiff, degenerated joint. We like to use the sitting position unless they're a hamstring strain, and then having them in that prone position is really good. And you can do both of these with that manual therapy. Your goal is to progress them into isometric training. When they're able to, you start loading that muscle. Your isometric patients, start them with multi-angle isometrics, 25 to 50% effort. You can skip sets or skip an angle if you have a sore angle, and you progress how many sets you run them through and the effort. Once they're able to go into eccentric loading, take them to eccentric loading. You can also do the long hold heavy resistance for your tendinopathies. Lots of times you'll run them through 1 or 2 sets of this, and then their pain is reduced, and now you can get them on eccentrics that same session. But with your isometric patients, your goal is to get them into isokinetic eccentric training. Same rules. Start off slow, 1 to 2 sets, 50% effort. You can increase their parameters by making it 2 to 3 sets or increasing their intensity to 75% effort. But when you increase their intensity or their protocol, when you increase them to the next speeds, drop their intensity back down to 50%. For your more active patients, you can take them into the medium speeds, and you can do isotonic testing for them as well. And then either way, you want to do follow-up testing at 4 to 6 weeks later. Even if they started out as an isometric test, you can have them then do the interrupted stroke test if they're appropriate for that. You have the slides here. You can also get the slides. Rob can upload them to the Isokinetics 101 if you're watching us on the recorded. So you can go through these slides. Basically, I covered an Achilles tendon plan of care, a Brostrom plan of care, and a non-surgical plan of care, basically an ankle sprain. So you have those slides available to you, and you can always email Rob questions you have about it, or you can just fill up his email, his inbox, and ask him a bunch of silly questions. That's always nice too. All right, John, I'd like to invite you back.
Thanks, Daniel.
Hey, we did pretty good with a little hiccup.
Excellent. Oh yeah, no problem whatsoever.
I was getting a spinning wheel over here.
So let's talk about foot and ankle next
Okay.
time. We'll add that in the shoulder a little bit because one of the things that we're really getting into is it's a progressive program. So if you're not familiar with some of the things he was talking about, and we confused about the nomenclature, go back to the isokinetic discussion that we had, where we introduced eccentric loading and deceleration training, because those are new concepts that people don't really talk about. And again, what we're doing is we're looking at force, which is force equals mass times acceleration, and we're varying the acceleration factor, not just the weight that we're using. So it really kind of gives us more sport-specific, more activity-specific functional types of loading. And that's the reason that we want to do it, is for people to understand that this is how we function. So we want to look at how we actually function. So looking at foot and ankle, perhaps next month would be perfect. And let's run some of those videos. Yeah, we're going to talk about shoulders, but shoulders are going to kind of follow some of the things that you already talked about, through the same kind of patterns. We want to do all of those types of things. We can start early rotator cuffs, and we'll mention all those. Great job. Let's get some questions and feedback back from everybody, and we'll take it from there. Yeah, Rob, you got anything?
I think Rob fell asleep.
Rob's watching Downtown Abbey.
Yes. All right. Well, everybody, thank you again. Oh, there he is. There he is.
There we go. No, sorry, I was just watching you guys listen to you go. But I am watching Downton Abbey.
Got to get caught up for that movie.
All right. So next.
All right, everybody. Thank you for joining us, and we'll pick up with ankle next time and include it with shoulder.
Yep. Thanks, guys.
Thank you.